A very good morning. I would like to welcome our chairperson, Dr. Kumar Ravi. A very good morning, doctor.
Good morning. I'd just like to confirm if Dr. A. Parivardhani is in the team. Has she joined?
Dr. Parivardhani, I can't hear.
Yeah, I can hear me.
Okay.
Yeah.
Dr. Supriya, our first speaker, has informed that she might be delayed. In case she is late, we will add her later.
Yes. I think we should go with the second speaker then, with Dr. Parivardhani.
Okay. Before that, I'd just like to give a brief introduction. Our topic is 100% accuracy in glaucoma diagnosis. If it is achievable, let's see. We have a galaxy of speakers with us from different parts of the country with vast experience in glaucoma. Let us begin with Dr. Parivardhani. To introduce her, is like she's a well-known face in glaucoma. She is from Shankar Nethralaya, Calcutta, Chennai, and I have known her since her postgraduate days because fortunately we are from the same institute, Bangalore Medical College, Minto Hospital, and later she did her fellowship in Shankar Nethralaya, and she has numerous publications and presentations and different forums, and she's a favorite teacher at her current institute. So let's learn accurate gonioscopy from Dr. Parivardhani.
Thank you, Ravi. Thank you. Can you hear me?
Yes. Your slide is visible.
My slide's visible. Yeah. Thank you, AIOS, for giving me this opportunity, and thank you, Ravi, for this kind invitation. I'll be speaking about gonioscopy, how to do it accurately, and how to accurately interpret the findings. So we know that the two major forms of glaucoma, the open angle and angle closure glaucoma, can be differentiated only by the assessment of the anterior chamber angle, that is by gonioscopy. The primary treatment of both these conditions are different. You would need a peripheral iridotomy in the angle closure glaucoma patients, and a medication should be started in open angle glaucoma patient. So the primary treatment is different. So we have to differentiate these two major forms of glaucoma. So gonioscopy is nothing but a clinical technique used to examine the structures of the anterior chamber angle. So it is a part of comprehensive eye checkup, and it is important in the diagnosis of glaucoma to differentiate between the various spectrum of primary angle closure disease and secondary glaucoma. So before doing the procedure, how to properly do this procedure, you have to explain the procedure to the patient and make sure that the patient is seated comfortably. And we have to apply topical anesthetics, and the examiner's hand should be supported well so that there is no undue pressure on the cornea. The patient should be asked to look straight, and the lateral canthus should be at the lateral canthus level marker. And if the examiner is using a handheld gonioscope, the gonioscope should be held closer to the lens. The room should be dimly lit, the slit lamp illumination should be minimal, and the beam height should be minimum, that is at 2 to 3 millimeters. If you are using a non-handheld gonioscope like the Zeiss or a Sussman, the examiner should, the free fingers, that is a middle finger, should be at the headband, and the other two fingers at the cheek, which is well supported, again, so that undue pressure on the eye is not applied. These are the various gonioscopes available. The upper ones are the Kobes, Barkans, Swan Jacob. The Morris lens are all direct gonioscopes. By direct, we mean that if we are examining the angle, superior angle, we are seeing the superior angle only. So we get an erect images with these lenses. The Kobes lens is used for diagnostic gonioscopy mainly in children. The Barkans, Swan Jacob, and Mori lenses are used intraoperatively for angle procedures. The below ones are all indirect gonio mirrors. The Goldman 3 mirror is the prototype. We have the indentation mirrors, the Posner, Zeiss, and Sussman. We mean indirect. These are mirrors, so the images will be inverted. So this would explain it clearly. So if you are examining the superior angle, we will be seeing the inferior mirror. So what we see at 12 o'clock will be seen at 6 o'clock. But it is not laterally reversed. So what we see on the right-hand side will remain on the right-hand side. What we see on the left-hand side will remain on the left-hand side. So when we put a gonioscope inside the eye, these are the normal structures seen in gonioscopy. The posterior most structure is the root of the iris, followed by the gray colored ciliary body band. Then follows the white colored scleral spur, the pigmented trabecular meshwork, and then the anterior non-pigmented trabecular meshwork, then the Schwal baseline. However, ciliary body band might not be seen in all patients. So mostly what often we see is the scleral spur as the posterior most structure. Here we see the scleral spur here, followed by the pigmented trabecular meshwork, the anteriorly non-pigmented trabecular meshwork. And then we see another brown line here anterior to the Schwal baseline, which is sort of wavy and sort of irregularly pigmented. This is called the Sampolisis line. So it lies actually anterior to the Schwal baseline and usually seen in heavily pigmented eyes. The trabecular meshwork is a major landmark in gonioscopy, whether to say it's open or closed. But sometimes in young patients, we see this faint TM pigmentation. So we are not able to say if these angles are open or closed. So in these situations, the corneal wedge technique helps. Here, what we do is we create a thin slit of light, which is maximally illuminated. And when the illumination is offset a little bit, that is inclined, we create two separate corneal reflections. So the anterior and the posterior surface of the cornea, and they intersect at the Schwal baseline. So if the distance between the iris root and the Schwal baseline is more, you know that the angle is open. But if you're not able to see this intersection, if it is dipping into the iris root, you know that the angle is not open. This can be done in the superior and inferior angle. However, for the nasal and temporal angles, this might be slightly difficult and not possible. So when we put the gonioscope, various structures can be seen, but we usually grade it by the posterior and most structure we see. So in the first three figures, we can see that here the ciliary body band is seen. Here posteriorly, the scleral spur is seen. Here the posterior trabecular meshwork is seen. All these first three pictures show that the angle is open. This picture shows a Sampolisis line, that is the Schwal baseline here. Here, no angle structures are seen. So these two pictures show us that these angles are not open. So also we have to pay attention to the iris contour. This picture shows that the iris contour is flat. This is convex. This is showing a plateau iris configuration, which is showing a double wave sign. Here the iris is concave. So once we examine the patient in the primary position without compression, next we have to do indentation gonioscopy, where we compress the central part of the cornea so that the aqueous is displaced peripherally into the angle and pushes the iris backwards. So in this picture, we can see that the angles are completely closed. We cannot see angle structures, the corneal, which is again dipping into the iris root. But in the second picture, we can see that the angle is open here with compression. The posterior most structure seen here is the scleral spur. We can also observe here the double hump sign. So with this indentation gonioscopy, we have opened up this. With see a brown structure here, a cursory examination would say that this angle is open. But when you do indentation gonioscopy, we see that whatever we saw here is actually not the trabecular meshwork. The trabecular is this structure. And what we were considering trabecular meshwork was a pigmented Schwal baseline. So even if we see a pigmented trabecular meshwork or see a structure similar to it, but shallow, you see, always indent and see if you're not missing a Sampolisis line as trabecular meshwork. If we don't have an indentation gonioscope with a 3-mirror or a single mirror Goldman's lens, we can also do a manipulative gonioscopy to see the over the hill view. Ask the patient to look into the mirror, or we can shift the lens to the angle where we want to see. We will be able to look over the iris and into the angle. So this can be done in non-indentation gonioscopy. This picture, we can see that the angle is closed, completely closed, and we're not able to see any angle structure. The second picture with indentation shows some part of the angles which are open, showing that they're open till the scleral spur. But the temporal part, we can see that it is not opening, and these are areas closed by peripheral anterior synechiae. So peripheral anterior synechiae can be very broad based. They can be filling some part of the angle. They can be focal with some areas of the angle seen in between, or they can be completely closing the angles like this. So in these situations, identification of peripheral anterior synechiae is not very difficult. But when you have focal goniosynechiae like this, very tiny goniosynechiae, peripheral anterior synechiae, they have to be differentiated from iris processes because they look little similar. How to differentiate from them? These peripheral anterior synechiae, they will look tented, triangular, that is, they will have a broad base. If you look at the iris process here, they're all slender. They will be here, they will be broad base, and they will not follow the concavity of the angle. Iris processes will follow the concavity of the angle. And when you try to indent, the iris will not be going back in when you have goniosynechiae. but the iris will go back when you have iris process. So it is very important to differentiate these two conditions, because peripheral anterocyanic is a pathological condition and iris processes is a physiological condition. Thick band of iris processes can be seen in axon-filled rigors anomaly, where you'll have anterior detached Schwalbe's line and iris process will be stuck to the Schwalbe's line. Indentation gonoscopy will also give us an idea if this patient has plateau iris. We'll see a double hump sign. The posterior most hump will be because of the anteriorly rotated ciliary body, and the second hump will be because of the lens edge. So again, we can diagnose plateau iris configuration with the indentation gonoscopy. Sometimes we can see this patchy TM pigmentation, trabecular meshwork pigmentation when we do gonioscopy. Whenever we see them, we should think of intermittent iridotrabecular contact which is occurring in them. So these eyes are at risk of angle closure. When pigmentation is seen uniformly, densely like this in all the angles, especially the superior angle, we should think of pigment dispersion syndrome, where sometimes if the Krukenberg spindle is very faint, we might be missing it on slit lamp examination. Once we look at the angle, then we'll go back and look at the endothelium, whether spindle is there. And this is a hallmark of pigment dispersion syndrome. Densely pigmented trabecular meshwork can also be seen in pseudoexfoliation patients. Sometimes pseudoexfoliating material can also be seen in the angle. These eyes are also at risk of angle closure because of the zonular laxity. The lens will move forward and you can end up with angle closure. In patients with neovascular glaucoma, new vessels can be seen in the angle even before we see them in the iris. So these are fine branching vessels which will bridge over the angle. And sometimes you can see peripheral anterocyanic also developing in them. And these should be differentiated from normal angle vessels. The normal angle vessels will be radially oriented. They will never cross the scleral spur and they're non-branching, thick vessels. So when we see finely branching,
can I request you to please sum up?
Yeah, sure. So there are various things. We can look for the patency of the trapstoma. Silicone oil in the angle can be seen. And inflammatory glaucomas, we'll see inflammatory debris or KPs in the angle. Foreign body can also be seen in the angle. Angle recession in post-traumatic patients with blunt trauma can be visualized. With CD cleft also can be seen, where we will see a white area in the angle. So blood-tinged lens canal should not be confused with neovascularization of the angle. Here we don't see any vessels. So other modalities are the red cams, NGS, goniopen. So some common mistakes which can occur are when we press too much on the cornea, or if the gonioscope is not kept parallel to the iris plane, you can get bubbles. Sometimes we can artifactually open up the angle also, which has angle closure. So I would like to say it's an important part of ophthalmic evaluation. It is an art, so it has to be practiced to be learned. But though we have so many imaging modalities, gonioscopy is still the gold standard for angle evaluation. Thank you.
Thanks a lot, Dr. Parvadini, for excellent talk. I know you're getting late for your operation theater work, but can we have a few questions before we?
Sure.
Okay, so in case we have to opt for any other instrument, suppose the patient doesn't allow to do gonio, or suppose such a situation is there, then is there any other instrument which you would consider as a second best, or it is a replacement to gonio in certain specific situations? I know it is irreplaceable, but still. Anti-segment OCT or anything like based on articulation?
The anti-segment OCT can be done. UBM definitely will require patient's cooperation. If patient is not allowing you to do gonioscopy, definitely UBM and anti-segment OCT can be done in them.
Okay. Dr. Supriya, Dr. Alkesh, if there is any question we can ask now, because she will be leaving the meeting now. I'll ask one more question. There are some people who say that they are able to get very good results based on their like a 2-mirror or 3-mirror gonio, and they don't want to shift to 4-mirror gonio. So do you think that the result that we get with the 2-mirror or a 3-mirror gonio is almost equivalent to like when we think about indentation result? Is it same, or I think like what do you think is like best for doing gonio?
So again, I would say many people don't use 4-mirror gonioscopes, indentation gonioscopes. They have been very comfortable doing manipulative gonioscopy. So if you ask me what to shift over to, the indentation gonioscopies are the best ones. But people do get good results. They have been doing for decades with single mirror and 3 mirrors. They have been getting good results with that. So what they're comfortable with, they are using it. But if students are starting to learn, I would ask them to shift over to indentation gonioscopes.
Thank you, Dr. Vardhani, for taking part in our IC and taking out your valuable time from your busy schedule. Thank you very much.
Thank you, Ravi. Thank you.
May I now invite Dr. Supriya Singh to deliver her talk. Just to introduce, Dr. Supriya is alumni of Minto Hospital, Bangalore. She has done her glaucoma fellowship from Shankar Nethralaya, Chennai. And she is an ex-consultant of Premda Birla Arvind Eye Hospital, Kolkata and Durgapur. And besides her academics, she knows how to handle stressful situation very well. Like till a few minutes back, we are not sure whether she will be able to join us, but now she is here. Let's hear from Dr. Supriya.
Thank you so much. The net connectivity is very slow over here. Are my slides visible?
Coming up. Yes, madam. It's visible now. Please go ahead.
Good morning, everyone. Thank you, Dr. Ravi and AIOS for giving me this opportunity.
And can I request you to be a little louder, please?
Okay. Measurement of intraocular pressure is an indispensable part of glaucoma diagnosis and management. Despite the availability of different types of tonometer, Goldman applanation still remains the gold standard. It is based on invert Fick law, which was later on modified to accommodate for corneal stiffness and surface tension. The equipment consists of a plastic biprism which is connected to the housing via a feeder arm. There is a measuring drum with a scale on it. The housing contains a weight which is mounted over a platform, and as one rotates the measuring drum, the platform also rotates. This in turn changes the angle at which weight is attached to the feeder arm. This weight is balanced by a counterweight which is placed vertically. Now, there are numerous sources of error which can be related to these instruments. These can be either apparatus related or subject related or observer related. Coming on to apparatus related errors, calibration error is one of the most common and forgotten source of error. Calibration is usually checked as 0 mm mercury level, 20 mm mercury level and 60 mm mercury level. As per the manufacturer, the tolerance for calibration error is 0.5 mm mercury at all levels of testing. CT guidelines are a bit more lenient. In our hospital, we follow a protocol of 2 mm mercury of tolerance at all levels of testing. This calibration is usually checked by using the weight bar. There are 3 lines on the weight bar. The center line is for 0 mm mercury level, while the second line is for 20 mm mercury level. The line at the end is for 60 mm mercury level. This is a small video. I'll skip this video. Okay, till this video runs. This weight bar is inserted on the, this weight bar is inserted on actually on the right side of the tonometer head, such that the long axis of the weight bar is towards the examiner. The measuring drum is set at 20 mm mark and the drum is rotated forward and backwards till there is a movement of the biprism. And this way, both the positive and negative errors are calculated. Similarly, errors at 60 mm level is calculated. This is another video, but I think the video is not going to run. So in a similar way, we measure the errors at 0 millimeters mercury level by simply rotating the knob forward and backward without using the measuring drum. This is a very, very simple technique and it should be used in OPD daily. For instruments which are less than 1 year old, annual checks is more than sufficient, but for instruments which are more than 1 year old, it is better to have monthly checks. In case calibration error is beyond the acceptable limit, then whatever is the amount of error, that error should be either deducted or added from IOP readings depending upon the positive or negative errors. It is not feasible for us to send the equipment every time to the manufacturer, as we usually have only one equipment. Devised a very easy technique of rectifying these calibration errors by simply cleaning the instrument by using compressed air spray and by lubricating it with a mineral oil based liquid lubricant. They also talked about making some changes in the alignment of weight and counterweight. By these small maneuvers, 95% of the errors are rectified, and if despite doing these maneuvers errors are not rectified, then the equipment should be sent to the manufacturer. A significant inter-instrument variability is noted between GATs of different instruments in a study by Dr. Ronnie George et al. This is particularly important in setups where multiple instruments are used. Therefore, it is advisable to perform baseline and follow IOP measurements on a single instrument. Fully open and the slit lamp knob should be fully rotated to provide maximum illumination, as inadequate illumination may result in insufficient fluorescence, which might underestimate intraocular pressure. And always make sure that slit lamp beam falls on the colored band on the tonometer tip. Presently, there is no consensus on how much to detect for central corneal thickness, but Ocular Hypertension Treatment Study and Early Manifest Glaucoma Trial Group have concluded that CCT is a powerful predictive factor for the development of glaucoma. Subsequent studies revealed that there are factors apart from CCT which have a bearing on the intraocular pressure measurements, such as corneal stiffness and viscoelastic properties of the cornea. But despite all this, the present consensus is that there is a positive correlation between CCT and IOP, and use of any global recalculation formula is unsuitable to find true IOP in clinical practice. So there is no point in taking corrected IOPs into account, as this is totally flawed. And clinicians should consider CCT into their thinking process by broadly dividing the cornea as thick cornea, thin cornea, and average cornea. And accordingly, they should take the decision. For example, in cases of ocular hypertension, if a patient has ocular hypertension and thinner cornea, then that patient has more risk of developing POAG than a patient who has average cornea. Similarly, a patient who has glaucoma and is having thinner cornea has more chances of progression than a patient who is having average cornea. GAT underestimates intraocular pressure in eyes with corneal epithelial edema, as it is easier to indent edematous cornea. Steeper the corneal curvature, more indentation of cornea is required. This results in greater displacement of fluid, thus causing an apparent increase in intraocular pressure. So 1 diopter increase of corneal curvature leads to 0.34 millimeter increase of measured IOP. Whenever there is a corneal astigmatism, the area of tonometer corneal contact changes from a sphere to that of an ellipse, and the diameter of tonometer corneal contact differs in different meridians. In cases of 3 diopters of more of astigmatism, Goldman suggested aligning the red line, which actually represents 43 degrees, to the flattest meridian, while Holliday suggested taking intraocular pressure in 2 meridians, first in horizontal meridian and then in vertical meridian, and then averaging these 2 readings. In cases of with the rule astigmatism of more than 4 diopters of astigmatism, there is actually an underestimation of IOP, while in cases of against the rule astigmatism of more than 4 diopters, there is an overestimation of IOP. In cases of irregular astigmatism, GAT readings are highly irreproducible, and therefore always other modalities for measurement should be considered. Constrictive clothing around the neck increases IOP acutely. Therefore, it is always advisable to loosen tight collars and ties before positioning the patient at slit lamp. Always make sure that patient sits comfortably at the slit lamp, and there should not be any extension of the neck, as this may inadvertently increase the intraocular pressure. Shifting the gaze from primary position, intraocular pressure first increases and then comes to baseline on maintaining that position for some time. This effect is seen in all gaze positions, but it is particularly relevant in cases of elevation, and it is of significance in cases of thyroid orbitopathy, restrictive myopathies, and in particular cases of strabismus like strabismus fixus, where globe is displaced from the primary position. No attempt should be made to check the intraocular pressure by bringing the eye in primary position, as this may increase the intraocular pressure. For those particular patients, IOP has to be checked in that displaced position only, as that is the primary position for those patients. Always explain the procedure to the patient beforehand. Otherwise, inadvertent lid closure may increase the intraocular pressure. So this is the right way to examine the IOP. Coming on to observer-related errors. If an object comes into contact with tonometer tip, then there is an inadvertent increase in intraocular pressure. This is particularly troublesome in superiorly mounted tonometers. So care has to be taken. Applanation of paracentral cornea does not have much effect on IOP measurements, but if cornea is applanated with the peripheral portion of the tonometer tip, then Myers of different arc lengths result. If there is little eccentric positioning, then there is not much of effect, but there is an overestimation of IOP with marked eccentricity. Repeated prolonged applanation attempts reduce intraocular pressure by 2 to 5 millimeters mercury. So always make sure that if patient is uncooperative and we need to repeat the intraocular pressure, just one more minute, I am winding up. Yeah, so if patient is uncooperative and if we want to repeat the measurements, then it is always better to wait for 5 to 10 minutes after explaining the procedure. Then only we should take the patient for measurement rather than going on repeatedly measuring the patient. Fluorescent precorneal tear film helps in observing the border between the tonometer corneal contact and precorneal tear film. In cases where fluorescence is too less, the apex of this meniscus is not visible properly, and this leads to underestimation of IOP. While in cases of excessive fluorescence, Myers are too wide, thus causing overestimation of IOP. We currently, because this new type of error has come because of the use of masks. So all those patients, if they are wearing masks while examining them, if mask touches the feeder arm accidentally, then the relation between the biprism and the assembly below changes, and thus leading to overestimation of intraocular pressure. This phenomenon is particularly seen with rigid masks like N95 as compared to surgical masks. So care has to be taken when the patient is walking in our OPD. We should always notice the type of mask which is worn by the patient, and during measurement keep an eye over the mask position, and if there is any such touching, then patient mask has to be adjusted. To conclude, regular calibration of instrument is a must. Make sure the patient is positioned properly. Illumination is maximum with adequate fluorescence, and if there is a high astigmatism, tonometer head has to be adjusted. Thank you so much.
Dr. Supriya, thank you for your excellent presentation. Just one small doubt I have. In this time of COVID era and the pandemic going on, is there any specific precautions that you take while checking the pressures through applanation for your patients? Or if I can extend the question, is there which would be a second instrument of choice in case we are not comfortable going for a contact procedure?
Yes, what I'm preferring right now is after measuring intraocular pressure in every patient, I wash the tonometer head with the soap water. This is what I am doing. I am not using any alcohol. The recommendation is to use even hypochlorite solution also, but I am washing it regularly with soap water after every measurement.
Okay, and if we have to have any other option, any other instrument would you recommend, or say a mass screening or for a larger group?
MCT can be used, but it is not portable.
Okay.
See, I think can take the place of Goldman applanation tonometer. So whatever it is, even if we do NCT in cases of glaucoma, we have to rely on GAT only. Maybe for cases of, for normal patients who are walking in our OPD, just for the screening purpose, we can use NCT.
Okay, thank you. Thanks, your point is well taken. This slight change in the schedule, on special request, we would like to move the presentation of Dr. Siddharth Dikshit little ahead. Just to introduce, Dr. Siddharth is an alumni of CMC Vellore. He has done his DNB and fellowship from LV Prasad Eye Institute and is currently a faculty at LV Prasad Eye Institute. I had the opportunity to work and study together with Dr. Siddharth at LV Prasad during my fellowship. I would say that he is a teacher par excellence, and I would count him in the league of the greats like Dr. Ravi Thomas, Dr. GC, Dr. Mandal. He's excellent teacher. Even today, I use some of the tips that he had given me during my training days. I'm sure his talk will be very useful for everyone. And he has two talks. The first one is case-based discussion on HBF, and second one is on interesting cases. So he has double talk. I think he will be taking one after another. So please note that he will have double time, like time for two talks. So Dr. Siddharth, I think you can start your talk.
Thank you. I hope I'm audible and my slides are visible.
Yes, you may start.
Yeah. I have never felt such pressure even during my DNB exams like you have created, Ravi, with the superlative words, which I humbly can say cannot be true. The teachers that I've had, they have been so great. The only similarity that I see between myself and Ravi Thomas is the shining head, if I can take off the cap. But given the fact that I have to go to the clinics, I'll defer that. Thank you so much for having me here. And hello, Kolkata. My alma mater is at Calcutta, and it's a pleasure to be back, even if it is virtually. And I hope and wish that I come back to Calcutta as soon as possible. So the first talk is about visual fields and how you can utilize it best to diagnose glaucoma. I will be talking about it in a manner so that you don't, one, miss a glaucoma, and second, don't misdiagnose a glaucoma. So what I have learned from Dr. GC and I'll be talking about today is correlation is the most important factor. The only reason why these printouts of visual fields and OCT do not have please correlate clinically statement written there is because they don't mention the diagnosis on the printout. So instead of thinking that if it's not written, not written to correlate clinically, you can ignore it. The fact is that it's entirely of our responsibility to call it glaucoma or not glaucoma when we are looking at the printout, and the company will not take any responsibility. All it gives to you is a set of images which are statistically calculated, colored, and shaded. So the first important thing is to correlate the location. Now, when we look at this printout, what we can see here is there are defects here in the superior hemifield. These fulfill the Anderson criteria and can be glaucoma. For example, candidate in the exam, they should say that I will correlate with the disc. Now, how do you correlate with the disc? Now, this is the visual field on the right-hand side and the optic disc on the left side, not visible clearly. So we will try to zoom in. And if we had to draw a diagram on this, we can easily draw. I'll just go backward and forward so that I can just focus on what I'm showing here. What you can clearly see here is an excavation along the neuroretinal rim and oval shaped cup. So we typically just mark the cup with a hash kind of a thing, and excavation as shown here with the dots. But it's not only important to zoom in and look at the disc, it's also very important to look at the nerve fiber layer defect. And we can clearly make out that there is a nerve fiber layer defect inferior temporally. and that is correlating with the excavation that was seen earlier. Now, this is what is called a perfect correlation. When you see an inferior defect, inferior excavation or non-fiber layer defect on the disc, and you see a superior scotoma in the visual field. So this is what correlation by location is. And this, if you put these two together, you can be sure that this is glaucoma. Now, what else do we need to correlate? It's not only the location, we also need to correlate the extent. Is the amount of defect that we see on the visual field correlating with the damage that is seen on the disc? And the best example of how you can do it is by forcing oneself to not only look at the extent or not only look at the nature of the defect, but also kind of quantify and serialize which of the defects on the visual field are the most significant ones. So if we look at the right and the
Dr. Siddharth, you're not audible.
Let's wait for a few seconds. There might be a lag.
Maybe he's disconnected. Maybe.
Hello, Siddharth sir, can you hear us?
Hello.
Hello, Dr. Siddharth. Can you hear us?
Sir, maybe his net problem.
Okay, so
Then next speaker continue then.
can we ask him to reconnect? Or shall...
Sir, I'm not sure whether he's able to hear us or no.
Okay, then we'll try to call him up and contact. Can you do it at the back end? And in
Yes,
the meantime,
I'll
we'll
just
do the
ask.
presentation.
Yes, sir. I'll just ask.
So, like in the meantime, I'll start my presentation. I'll be sharing my screen.
Okay, we can ask him to restart it.
Okay.
Yeah, thank you, sir.
But I'm not able to share unless and until he stops sharing. I'm unable to share my screen.
I guess host can do
Yes,
it.
sir. Continue, sir. I'm stopping the sharing.
Okay. At the back end, please try to contact and see if we can restart once I finish. So is my slide visible?
Not yet, sir.
No, sir. Not yet.
So I've started sharing. Once it is visible, please let me know.
I guess he's with us, Dr. Siddharth. Hello, sir.
I'll stop sharing then.
yeah, so while I was connecting the lines, probably the internet disconnected me.
No problem. So we can continue with your presentation.
Right, I'll just start sharing the screen again
Yes.
and go to my PowerPoint. Right. So what we can see here clearly is the extent of damage on the disc and the extent of defect on the visual field matching quite well. And if we practice this regularly, we can comment on the extent of the damage and the correlation of that. So while we had the visual fields correlating perfectly well with the visual fields in the last two examples, there can be a situation where the visual fields fail to catch what is happening on the disc. What you see here, though it is a little unreliable disc, the pattern deviation plot does not show any defects. So this was quite repeatable, and even when we had a reliable field, there was no defect on the 24-2. This is the 24-2C pattern, which has 10 additional points. So if you see this C here, these are the additional 10 points that are there on the 24-2C program. And these are the points which were typically missed by the 24-2 traditional program. And these are supposed to catch glaucoma early. However, even this seems to be quite normal. This would be expect to see a normal disc, but is the disc normal? No, when we look at the disc, we can clearly see a large size disc with the inferior rim being lesser than the superior rim, possibly an excavation here. There might be concentric thinning superiorly. What is very evident is a nerve fiber layer defect inferotemporally. So before we call this pre-parametric, we need to do a 10-2, for which for this patient, we don't have the printout. But what will help here is again an OCT. So this is a situation where the visual field had actually missed the inferior nerve fiber layer defect. And though the disc showed a significant damage, the visual field was unable to pick it up. So just like when you get, or say the PM office gets information about a security threat from one agency, it will go to another agency to confirm, and then probably confirm it with the foreign services before it can actually go on an all-out war. So before we decide on treating or not treating a patient, we should not look at only one parameter, either the visual field or the disc or the OCT. Just like the PMO would do, consult with each of them separately. So individual assessment of disc followed by individual assessment of visual field, followed by individual assessment of OCT. If two of them point towards the same thing, then it is probably glaucoma. If all of them do it, then there is no doubt. Even if all of them don't do it, but two of them do it, then you can be quite sure that this is glaucoma. If not, then we have to reassess and relook. Now, the correlation does not extend to only the disc and the nerve fiber layer defect. It goes beyond and must go beyond. Now, what we see here on the right side 24-2 CETA standard printout is in the inferior hemifield defect that is occupying the arcuate area and the nasal area involving the central points and the paracentral points. Looks quite typical of glaucoma. But is there a surprise in hold? The 10-2 also correlates quite well with the what we saw there on the 24-2. How does the disc look like? Now, this is the disc. Does it correlate with what we have seen there on the visual field? Now, the superior rim is lesser than the inferior rim. Is this a thinning? Is this an early nerve fiber layer defect? Let's zoom out. Yes, it is a nerve fiber layer defect, but glaucoma is not the cause of that. What we can see here is clearly hemorrhages because of a branch retinal vein occlusion, which can result in nerve fiber layer defects, also cause pallor of the rim, but the defect that we saw is not because of glaucoma. Now, there are certain hints which we can get in the visual field, which will tell you that this is not glaucoma. One thing that is typical of other defects is a very straight margin here. The defect has very straight margins, which is atypical of glaucoma. And in fact, you are likely to see a slope. So denser points centrally with less dense points in the periphery And whereas this scotoma is very strictly localized. It is not an absolute scotoma, but if you see what is called the slopes of the scotoma, the areas adjoining the defect, they are all completely normal. Whereas the glaucoma, this would have gone from probably 27, 26, or increased from 27, 29, 31, and increased in various directions. That's a gradual slope, whereas this is a perfect cutout and the straight margins, which can be hints to pick up defects which one might think is not glaucoma. Right. Why are the slides playing again? Right. This is another example of pre-parametric glaucoma when the HVF 24-2 and 10-2 have not been able to pick the defect up. The same patient, but the nerve fiber, it shows pretty well on the OCT. So there is important aspect to remember that the 10-2 has a separation of only 2 degrees compared to 6 degrees on 24-2. So what seems like a defect, which may not even follow the Anderson's criteria, actually it does, but looks like a very minimal defect on 24-2, and you might think this is an early glaucoma. When you do a 10-2, you will find that it does not only occupy a large part of the center, but also is very close to fixation, which means it is close to threatening the vision. So this is a glaucoma where you really need to be aggressive on treatment, lower the intraocular pressures like you would do for an advanced glaucoma. And this is the disc, again correlating with the inferior near notch and excavation there. Sorry for the photograph. So what we learn from here is that sometimes we may not have a significant defect on 24-2, but once you have the fixation central points involved or the paracentral points involved, so these 4 central points along with any of these paracentral points involved, one must do a 10-2, and it may throw a surprise or a timely caution and warning that you need to control this a little more aggressively. So just to sum it up, correlate the location of the defect on the visual field with the damage on the disc. The inferior defect should correlate with a superior disc damage and vice versa. Correlate the extent, getting into the practice of looking at the severity of the rim damage, especially if you are looking at one eye, and both eyes put together if you have the photographs and you can draw a disc diagram. Do not forget to look at the retina beyond the disc and the nerve fiber layer defect. Sometimes non-glaucoma related pathologies can easily mimic a glaucoma related defect. There can be glaucomas which are pre-parametric, and then you need to consult your brain and your examination and the OCT. And do not forget to do 10-2 whenever you see a central or paracentral point involvement on the 24-2 program. Thank you so much. And if there are any questions, I'll be happy to answer.
So is your presentation part complete, or like you have anything more?
Yeah, this one is done, Dr. Ravi.
I think you can go ahead with the next presentation. We're running short of time, so you can continue with the next one.
Okay, because there was no buzzer, I thought I was ahead of time. That can never happen. Okay, so
You might have to cut short little the second presentation because you have roughly 7 to 8 minutes only now.
Okay, just let me know when to stop.
Sure,
I can probably just stop at.
Sure, sir. I should just interrupt.
Right. Right. So let us jump directly into a few interesting cases. I will try to speak a little fast in order to cover more. So a 38-year-old housewife just wanted a second opinion because she had been advised surgery elsewhere. 20/20 N6 in both eyes, anterior chamber completely normal, intraocular pressure 16 and 18, open angles, and on maximal therapy with 4 glaucoma medications. This was from an age where you didn't have the other drugs. And this is what the disc looks like. The right eye disc on the red-free and the colored image, the left eye disc similarly on the red-free and colored image, and we can quite easily see that the discs are healthy. The visual field is normal. The corneal thickness is good, quite normal within the normal range near the 520 micron cutoff. The OCT is also normal. So what has happened? Why has the patient been advised to do surgery? Diving into the records that the patient had, we saw a succession of high intraocular pressure recordings. Even the recording just the week prior to the visit with us, the intraocular pressure was recorded as 27 millimeters of mercury in both eyes. The interrogation into how it was done revealed that it was done with a non-contact air puff tonometer. And this lady, who was very apprehensive during the applanation also at our clinic, had this habit of squeezing the eye. So if the patient squeezes the eye or has this kind of a straining action during that brief pulse of air touching the cornea, the intraocular pressure can be falsely raised. Now, what did we diagnose this patient as? We wanted to rule out ocular hypertension. Okay, we did not see glaucoma, but is there ocular hypertension? So in a stepwise manner, we started discontinuing the intraocular pressure. And on a day DVT, finally, after 4 to 5 months, the intraocular pressure on Goldman applanation tonometer measurements was 13 to 16 in the right eye and 13 to 15 millimeters in the left eye. So while the NCT is a very good screening tool, it should not be used to diagnose or monitor intraocular pressure in glaucomatous eyes. The medications, if the patient is on, and you can watch the patient over a period of few months, medication should be tapered gradually or stopped gradually, and wait for the washout period before determining that the pressure is normal even after stopping a particular drug. This is a very interesting patient. A young man had undergone LASIK 2 years back, had a retinal detachment because he was a high myope. 6 months following the SOR, he had a decrease in vision with central corneal haze. The intraocular pressure measurements were 2 millimeters of mercury. The intraocular pressure in the left eye remained low through a period of many months, but the disc started showing glaucomatous damage. So nobody was able to figure out what was happening and why, despite a low intraocular pressure, the disc damage was going on increasing. But an investigation into the corneal haze, and what you can see very clearly on this slit lamp image here, when we retrospectively looked at this patient, was this gap between the flap and the residual cornea. This is the interface fluid syndrome. So between the flap and the residual cornea, you have a collection of fluid. So any device that measures the pressure of the eye on this cornea is actually measuring the pressure of this particular chamber and not of the eye. So the paradoxical low IOP is a result of this interface fluid syndrome, and the way we can counter it is by checking the intraocular pressure in an area where you don't have the fluid pocket under it. So a tonopen can be used, or an eye care can be used to check the intraocular pressure on the peripheral cornea. And for this patient, it was 38 millimeters of mercury. He was initiated on anti-glaucoma medications, and gradually it came under control. And after 4 weeks of treatment with anti-glaucoma medication, the pressure remained controlled, but the damage by then had happened. So because the GAT relies on the central corneal thickness, after LASIK, it may become unreliable, especially if the cornea is edematous or has interface fluid. If you have such a situation, tonopen or an eye care may not be a bad instrument to check the intraocular pressure in the peripheral cornea. The third interesting case is of another young man diagnosed with a unilateral angle closure, and he was started on topical steroids along with pilocarpine, as what was advised to undergo AIOC. He had come for a second opinion. The left eye seemed to be quite normal. The right eye had decreased vision and 20 occludable angles over 270 degrees, the unilateral occludable angles. The central and the peripheral anterior chamber were both quite shallow, as you can see in these slit lamp images. And in that situation, should we be going and doing a AIOC or not? We ordered a UBM and B scan because we saw something on the fundus undilated and did look something of a run of a mill kind of a thing. So the fact that the situation was unilateral and the fundus macula didn't look normal, we ordered a UBM and B scan. And what we can see is, apart from angle closure, which is visible in many quadrants, we can also see a uveal effusion here. And on the B scan, we can see a broad area of choroidal detachment and the sclera to be thickened. The disc was healthy, but what you can see is ILM folds at the macula with a large choroidal elevation inferotemporally. What is the diagnosis? This is posterior scleritis causing choroidal effusion, the ciliary body detachment due to the uveal effusion going so much anteriorly and causing a shallow anterior chamber centrally and peripherally. So he was treated by our uvea specialist. Investigations were performed, and instead of a PI and pilocarpine, what this patient needed was cycloplegic. And very soon, the intraocular pressure became normal, the AC became deep, and over a period of time, this patient recovered quite well. So if you have a unilateral angle closure, if you have any abnormality visible or you suspect any abnormality at the macula, do perform a UBM and B scan to rule out a secondary cause. I will stop here and will be happy to answer if there are any questions.
Thank you, Dr. Siddharth, for excellent presentation. From your first presentation, I just want to clarify one thing, that there are some new perimeters which are coming up, including some of them which are having audiovisual unit which the patient can perform at home or at the waiting area. So are you exploring any of those or any new thing which is coming up in perimetry examination?
Yeah, in fact, the iPad-based tool that has come up, we have found it very useful. And look, these can never replace the perimeter that we have in our clinics. But in an era where the patients find it difficult to travel within cities, and there are so many people who are dependent on the big cities for their perimetry, they have to travel hundreds of kilometers. If we can have something that comes even close, at least for the diagnosis, I don't think they can be good enough for monitoring because the test fetus variation is likely to be high, which needs to be, I'm not saying that they are high, but intuitively, you know that they are likely to be high. May not be very good to monitor, but if you can catch someone with a glaucoma sitting hundreds of kilometers away on a Zoom call like this, I think that will be a revolution. We need to wait on what these larger studies show. But I am very hopeful, and I hope someone will give us something that once you can put it on a mobile and diagnose glaucoma, we'll take a photograph, do a gonio remotely.
Thank you, Dr. Siddharth, for taking out your valuable time from busy LVPI glaucoma OPD. Thank you for being a part of our IC.
Thank you so much, Dr. Ravi. Thank you, AIOS.
Thank you so much, Doctor. Dr. Kumar, Ravi, I would just like to check that we have more 2 presentations to go for this session, if I am not.
Yes, 2 more presentations.
Yes. Okay, sir. Thank you.
So the next presentation is by myself. So I'll be sharing my screen now. My presentation is on anomalous disc. I hope I'm audible and my presentation is visible now.
Yes, sir.
Okay, thank you. At the onset, I would like to thank the speakers before me for taking part in this IC, and to the organizing committee AIOS for allowing us to be here. My presentation is on anomalous disc. Ideally, it should include congenital anomalies, but I have included the discs which create problem in diagnosing of glaucoma, or those discs which can be a differentiated diagnosis of glaucoma in clinic. So traditionally, we know that these, whenever we evaluate a disc, we have these 5 things to keep in mind. Like we evaluate the ring, the scleral ring, the rim, the NRR, the retinal nerve fiber layer defect, and the region of peripapillary atrophy around the disc. And then if there are any hemorrhages, like here we can see area of early RNFL defect. And here if we see, like there's a early disc hemorrhage. If you see here again, there's a disc hemorrhage and RNFL defect. So this is a traditional teaching that we have. And most of us are practicing this and are successful reasonably in diagnosing and treating glaucoma based on this teaching. But when we come out of our schools or colleges, and once we are in the field, we have discs like these, but it takes some time to understand what exactly are we looking at. Is it a Photoshop or is it actually a disc? Let's see if I can make things a little simple for my audience. So anomalous disc, many times the etiology may not be known, the visual acuity may be affected or may stay unaffected if it's a small anomaly, and there might be disorders of central nervous system associated. So coming up with few cases to discuss, there was a 45-year-old male who had a defective central vision, who was referred to us for glaucoma evaluation, and he had CSR in the past. And when we saw his perimetry, there were some telltale signs of early glaucoma changes, typically in the central part. When evaluated, he had open angles, not much of glaucoma signs. But when we saw the disc, we saw that there is a typical area of depression close to the center. And this was a case of optic disc pit. So these pits are mainly because of closure defects in embryonic fissure. They can be bilateral, mainly they are in temporal and central areas, and sometimes they can be associated with CSR. Here you can see that the FR is dull, so the patient had previous CSR, and they may have macular holes also. So instead of glaucoma, he requires more of retina intervention. Sometimes they can have CSR, so they may require vitrectomy or lasers also. And the patient, he was referred to us for glaucoma evaluation for 24-year-old female with open angles, normal pressure. Her disc was little suspect, so she was referred to us, and this was her field test, the HPF test. So it's like ambiguous. We do not get any useful information from this, but when we see the disc, we see that there are round areas of elevation at the disc surface. So this is a typical case of optic disc drusen. And these are abnormalities which arise because of abnormal intracellular metabolism and calcification of mitochondria in the cells. They can be bilateral and they're possibly present at birth, and once with age, they start getting exposed at the disc surface. So if there's any confusion, B-scan can help us in identifying the calcification here, and it can, like the differential diagnosis can be disc edema or pseudodisc edema and a prominent disc. Usually these cases do not require intervention. I mean, we normally follow up these patients. These diseases can be associated with some phakomatosis and neovascularization and hemorrhages. So they basically require follow-up. Coming to the third case, like most of you would have recognized immediately that this is not glaucoma. This was referred for glaucoma evaluation, a 40-year-old male who had just come for a class checkup, and there was myelinated nerve fiber. Usually the myelination ends at cribriform plate. Behind this only the nerve is myelinated, but sometimes in some cases it can go beyond the cribriform plate, beyond the disc margin, and in some cases it can survive even after birth. So it can be present in 20% of the cases, males more than females, and there can be systemic associations with neurofibromatosis and some craniofacial abnormalities also. Coming to the fourth case, a 45-year-old female, one-eyed, other eye had total degenesis, and right eye, this particular eye had anterior segment dysgenesis. She had this kind of a disc picture. Her vision was little low, 6/18, and she was referred for glaucoma evaluation. So at first impression, it looks like a glaucomatous disc, but if we evaluate properly, we see that this is a small disc in the center. This is the actual disc, while it is surrounded by a yellow-white ring, which is a false disc. So the actual disc is a small hypoplastic disc, which may have no fibers less than typical 1 million fibers that we have in a normal eye, and these patients usually have subnormal vision. These patients do not require glaucoma treatment immediately, but if they have high pressures or perimetry changes, then we may consider glaucoma treatment, but the disc per se is not glaucomatous. These cases may have other associations like strabismus, nystagmus. As we are told, they have subnormal vision, and they can be systemic associations with anencephaly and other CNS abnormalities. Sometimes these patients may have amblyopia also. Now, coming to another case, this patient was referred for evaluation of poor vision in his left eye. He had a history of road traffic accident, and he was started on glaucoma medication based on disc picture. But the disc picture typically is of a pale disc, which has possibly happened because of optic nerve compression following trauma. And whenever we have pale disc, we should be aware that these are more of a neurological changes rather than glaucomatous changes, especially total disc pallor, or if there's inferior or superior disc pallor, we need to rule out glaucoma in these cases. This could be because of NAION trauma or other abnormalities. Coming to another case, this was a 42-year-old lady who complained of headache, and she was referred for disc evaluation. If you see the disc here, it's not very clear. It has fuzzy borders, not the typical disc that we have. If you follow the 5R rules, the rim is not very clear. The neuroretinal rim also, and the ring is not very clear. The rim also is difficult to identify. So this kind of cases is possibly because of papilloedema, and it is because of raised intracranial tension and requires more of a neurosurgical intervention rather than the ophthalmic intervention. As an ophthalmologist, we need to identify these cases as disc edema cases and refer them to the neurosurgeons for the evaluation. Coming to another interesting case, this was a male 37-year-old patient who complained of diminution of vision for last 3 days. Another significant history with this patient was that he was having high pressure initially, and when he presented to us, he had AC, shallow AC, and there was high IOP also. But if we see this is a typical disc of malignant hypertension. Because of excessive high pressures, we can have disc changes like this with associated hemorrhages. And because of sudden lowering of the blood pressure, he had unusual choroidal detachment, and this choroidal detachment was pushing the lens iris diaphragm forward, causing a secondary angle closure and raise in the IOP. Once he was treated well for BP control, the thing subsided by itself. So it's not glaucoma, even though the IOP is high. Not every high IOP is glaucoma, and we need to be cautious while diagnosing glaucoma. Now, coming to this interesting case, this was a routine examination of the fundus of a patient who had come for cataract surgery. The patient had no evaluation in the past, and when we saw, we thought that the patient is having 2 discs. But when we saw in detail, the upper one was the actual disc, and it had the vessels coming out from there. And the lower one was, in fact, an iris, the retinochoroidal coloboma. But because of this vessel pattern, it was giving appearance of a double disc. So this also happens because of abnormal embryonic closure. Sometimes it can be bilateral, and visual acuity is usually affected in these cases. It can have association with retinal coloboma syndrome and CHARGE syndrome. And if it is unilateral, that particular eye can have amblyopia and requires amblyopia management. Surgically, we need not do much in these cases. But to remember that these cases are not typical glaucoma, even though because of coloboma, the lower part of the disc is showing changes which resembles glaucoma, but differently with IOP under normal limits. It's not a case of glaucoma. Now, for confirmation, if the visibility is poor, we can do a B scan and see the deficient sclera in the lower part. Other rare disorders, in morning glory disc, we can see that there is a central tuft of glial tissue, and the vessels, in an unusual fashion, arise from one particular margin, and there is a collection of annular pigments around the disc. So this, because of this tuft, it gives the appearance of a large cup, which is sometimes falsely diagnosed as glaucoma. This is not a case of glaucoma. Typically in morning glory syndrome, we have this vascular pattern, a large disc with surrounded peripapillary atrophy with pigmentation. In very high myopes, in degenerative myopias, we have deep excavation. Okay. And this is on the last slide. In tilted disc also, we have like the disc tilted congenitally, which gives a false appearance of glaucoma. I would like to thank my institute and my colleagues for helping me with this presentation. Thank you. May I now invite Dr. Alokesh Ganguly for his presentation.
Thank you so much, sir, for summing up at in time.
Dr. Alokesh is a well-known glaucoma figure in Calcutta. He is a fellow of Arvind Eye Hospital. At present, he is a consultant at Priyamada Birla Arvind Eye Hospital. And he will be talking about the role of OCT. Before he begins his talk, I would like to say that Dr. Alokesh is an excellent person with excellent work-life balance. And let's hear with him regarding his usage of OCT in glaucoma. Dr. Alokesh, please.
Thank you, Ravi. Am I audible?
Yes, you are audible, sir.
Share my screen. Yeah, a very good morning to all of you. I'll be talking today on optical coherence tomography in glaucoma, the common pitfalls. I have no financial interest. So the question first arises is why are we depending on such imaging techniques like the OCT? Because firstly, the visual damage is a relatively late phenomena, and disc photography or clinical examination even shows the higher inter-observer as well as intra-observer variations, and tests like visual field demand performance. The ocular hypertension treatment study showed that almost 86% of abnormal and reliable fields were not confirmed on retest, and it required 3 consecutive field tests to reliably confirm glaucoma or to confirm progression to glaucoma. Whereas on the other hand, it has been shown that both macular and nerve fiber layer thicknesses can have a positive correlation with glaucoma. We should think about the 2 types of OCTs, the time domain OCTs and the spectral domain OCTs. The time domain OCTs are gradually being phased out because the spectral domain OCTs have got some benefits. The time domain OCT measurements are dependent on the time lag on the reflected interference of the waves, whereas in frequency domain measurements, we get a more uniform bandwidth. In time domain OCTs, actually radial line B scans are performed.
Hello, sir. Can you hear us? There's an internet issue.
I think Dr. Alokesh is disconnected now. So we can't hear you. Kindly please reconnect.
Yeah. Yeah, am I audible now? I'm sorry, I think suddenly the internet connection dropped.
Yes, you're audible, sir.
So as we were talking about in the time domain OCT, there are radial B scans which measure less than 5% of the mapped area, and the errors are extrapolated or propagated across a large area, and when they are measured, they miss small lesions which may fall in between the 2 lines of B scans. Whereas in a spectral domain OCT, the number of B scans are far more, about 241, and they enable us to get a 3-dimensional view and measures about 100% of the mapped area. So this is a picture showing how the radial A scans are done on the disc. And this is a picture showing how the results are calculated from the right eye in a clockwise fashion and in a left eye in an anti-clockwise fashion to give us the specific double hump patterns. So one of the most important things that we must remember is the signal strength value. What is the quality of the OCT that we have performed gives us. That is, a signal strength of 6 indicates a good quality in a time domain OCT. And in a spectral domain OCT, like for example, the spectralis is the signal strength ratio of about 15 or more, which gives us the indication of a good quality of a scan performed. The other thing that we must remember is the centration on the disc. because the retinal nerve fiber layer closer to disc is thicker and those away fans out and gets thinner. So if the circle is displaced inferiorly, the superior sector will artificially appear to be thicker, while the inferior sector, which is farther away from the disc, will artificially be measured as thinner as compared to the normative database. So these are the basic printouts. I think all of us are familiar with it. Nothing much to go about it. And this color coding is dependent upon the percentage of the normal population against which it is scanned. So one most important thing about the parameters that we should remember is that an inter-eye asymmetry of greater than 30% is a significant difference. We'll illustrate a few cases. The first case is a male, 46 years of age, and there's a mean diurnal, which you can see is more or less within the normal range, slightly higher CCTs, highly myopic, with no family history. So these are his optic disc photographs, red free photographs. You can see that there is a slightly larger disc on the left side with a beta geometrophy. And if you look at the HVF with the pattern deviation plot of the left eye, you find depressions in the scotomatous zone of the inferior arcuate region. But once you do the OCT, you find that the left eye has almost reached a floor effect. Now, is this an advanced effect of RNFL? Actually, no. Because if you look at the signal strength, you see that it is at the unacceptably low level. So once you repeat the OCT with the proper signal strength, the RNFL comes out to be much better. Even then, it shows some thinning of the RNFL, which we will explain as the changes in a myopic patient. And if we look at the repeat fields, we can see that because of better performance, it has come out to be normal. So one of the cardinal pitfalls that we have is that we don't look at the signal strength and we look at the color-coded map and conclude our decisions. So we should always look at the signal strength before judging the analysis to be abnormal. That is the first point. Coming to another case, 33 years of male, high myope, father POAG suspect, normal HVFs, normal diurnals. And if you look at the photographs, the red free photographs and the disc photographs, here slightly larger cup disc ratio, and when you look at the OCT picture, you find a generalized thinning of the retinal nerve fiber layer with a good signal strength ratio. So what is going on here is that if you look carefully along the major vessels, there are deficiencies of the retinal nerve fiber layer. These are in a high myope actually pseudo RNFL defects. And we have to remember that all myopes have low average nerve fiber layer thickness. So a significant proportion of these myopic eyes will be classified as outside normal limits when compared to the normative database. So this is the mistake that we should not commit. This is the normal person with no glaucoma. The third case is a middle-aged diabetic lady, a mean diurnal of 18 to 19, CCT slightly in the thinner range. And if we look at the disc picture, you can see very clearly that there is an inferior thinning in the right eye with a reabsorbing splinter hemorrhage and a corresponding RNFL defect. But once you do the OCT, you find that it is absolutely normal. So what is happening? When we do the visual fields, we see that there is an absolutely corresponding lesion here. And in the time domain OCTs per se, basically, as we were explaining, there are A scans which run radially at 30 degrees differences. So two-line A scans which run between these two areas and the lesion falls in between the two scans will result in a normal OCT. Case number 5 is a 44-year-old gentleman whose father has glaucoma, open angles with these pressure distributions. These are the visual fields of the patient and the retinal thickness maps. Now, if we go back, we see that basically this gentleman in the right eye again has an absorbing hemorrhage with a loss of RNFL, which is better evident on the red free photographs. So why is the OCT missing it, or actually is the OCT missing it at all? Actually, the OCT is not missing it, but the color-coded map is missing it. If you look here, there is a difference in the eye maps of 30 between the two eyes, and the inferior average also has a difference of 30. So between the right and the left eye, inter-eye variation of 30 measurement is significant. So actually the OCT is picking up, it is us, the people who are interpreting it, who are missing it. So always remember that inter-eye asymmetry of greater than 30 is always significant, and we should look for the clues of the clinical picture to show that the OCT can pick these lesions up.
I think.
Yeah, one second. It's the last slide. Okay, so basically we have a patient who was being treated for glaucoma based only on the
Sir, we can't hear you. Sir, if there is a problem, can I request you to please switch off your camera?
Okay, so hello.
Yes, sir, we can hear you.
So you can conclude it.
The last slide. Yeah. So basically, when we look at the visual fields, we see a pie in the sky appearance, superior quadrantopia, and this is the calcified tubercular lesion which was causing it. So we should always remember that these common pitfalls in OCTs have to be avoided, and we should have a look at the whole picture and remember that 1 + 1 does not always make 2 in the human body. Thank you.
Thank you, Dr. Alokesh, for the excellent talk. Since we are running short of time, I would like to thank all my team members for this IC, for their valuable time they've spent, and so nicely they have elucidated the topics that they have covered. Thank you very much.
Sir, extreme apologies to interrupt, but we have a couple of minutes before starting the next session. We can have...
Right. Before I hand over the podium to our next participant, yes, I would like to thank the hall coordinator, our audiovisual team, the support team of AIOS Organizing Committee, and all my colleagues once again for being a part of IC and helping us out. Thank you very much. Thank you.
Thank you, Dr. Ravi. Thank you.